thank you to the John Rylands for the free use of the venue and all their support with the event. I'm Manchester born and bred, and the university means an awful lot to me, and the John Rylands building has a huge resonance for those of us who live in Manchester and those of us who work at the university. And UKMed itself is also hosted at the university, working alongside the Humanitarian and Conflict Response Institute. So huge support and really appreciated and valued. Thank you to our fantastic volunteers. Those of you who are here, those of you who are online, UKMed started as a volunteer organisation, and I've never ever had an occasion when I've not been impressed by volunteers always coming forwards, and sometimes volunteering, and perhaps often volunteering for the most difficult things. But volunteers across the board, organisations like UKMed only function if they have the base at home in order to support people going out. So it's volunteers across all the sections of our work. And thank you to you, our guests here, for your interests and support. So I was asked to start off by discussing how I founded UKMed and our first responses. Well, interesting talking. We have a distinguished consultant from Wythenshawe Hospital in the audience today, who actually I met when they were junior doctors, and now they're very, very distinguished consultants. But it started out when I worked in South Manchester. I was appointed to be a consultant in accident and emergency at what was then Withington and Wythenshawe Hospitals. It's now just the University Hospital of South Manchester at Wythenshawe Hospital. But before I took up the post, the chairman of the Health Authority rang me and said that there'd been a terrible incident where a young boy had got impaled in the back of his head on railings in Altrincham, and that the rescue service, the fire and rescue service, couldn't get medical teams from any of the local hospitals to come out because the surgeons, surprise, surprise, and the anaesthetists, surprise, surprise, were all in the operating room. They couldn't be spared. So he said, you have to solve the problem so that we can give support outside of the hospital, because we're talking about a time when there were no paramedics. In fact, we were instrumental in bringing paramedics into the health service, particularly here in Manchester. Manchester had the largest paramedic service at the start of the paramedic movement. He said, so I'll do anything to support you, but there's no money. So welcome to the NHS. So I said, what we need a team of senior surgeons, senior anaesthetists, senior A&E people, senior nurses, who would, in their time off, which they didn't get much of, in their time off, would volunteer to be on call to support the ambulance service and the fire and rescue service. And that would have to do their own training in their own time and raise money for all their own equipment. And I got lots of volunteers. And it's always been that way. People will come forward. And so that principle of having a register of volunteers on call, which we established then, of senior clinicians across a range of specialties, doing additional training and working with and being seconded from the NHS was seconded then. And we've used that principle all the way through to the present day. Having established our pre-hospital care team, which we call the South Manchester Accident Rescue Team, SMART. We thought of SMART first, and then what fits with it. So we thought, well, South Manchester, well, that's an easy one. Accident Rescue Team, so SMART. We called ourselves SMART, and the public supported us enormously. The Manchester Evening News really took to us, gave us a lot of local publicity. The Rotary Club funded us, so we raised money, we got a lot of equipment and did a lot of training in a very short period of time. And then in December 1988, the earthquake in Armenia occurred. And we were asked to join a combined effort with the Fire and Rescue Service to go to the earthquake in Armenia. And I'd never been to anything like that. I thought as an A&E consultant I understood about seeing difficult things and dealing with major emergencies. I was not prepared. None of us were prepared. We were asked to go. We didn't just turn up. We were asked to go. But it was very difficult for us, and I realized that if we were going to do this, we needed to go to another level in terms of training and equipment. And then we'd only just got back home, and I was phoned at home to mobilize the team for the Lockerbie air disaster. And we then were taken by the Royal Air Force up to Lockerbie, and we worked there. So it was in a very short period of time, over a few weeks, at the end of 1988, I'd gone from a local A&E consultant with pre-hospital care experience into the managing or being involved in one of the biggest sudden onset disasters of the 20th century and the biggest terrorist attack on British soil. And so I had to make a choice, either, it seemed a very big thing to do, either not do this again, which would have been reasonable, or if you're going to do it properly. And so the team all mobilized, and we got even better, doing more training, and we then were invited by the Iranian Red Crescent to respond to an earthquake in northern Iran in 1990. And we had no diplomatic relations with Iran at the time. We had no visas, no consulate, no embassy. But the Iranian Red Crescent invited us, so we went. And it was a very different experience. We knew as a team that we were better prepared. We knew what to expect. We were very well equipped. We were familiar with the process. And I think we did a very effective job, so much so that a year later, when the Kurdish refugee crisis occurred after the first Gulf War, and there were many Kurdish people going into Iran, there was a lot of attention given to the Turkish border. But the then Iranian government asked us, would we set up a field hospital on the Iran-Iraq border, which we did, and we got a much bigger team. And those events really cemented us as a specialist medical team that could respond to a range of events. I will speak a little later about how we then expanded that. But all that early experience from the South Manchester Accident Rescue Team, which we then evolved into UK Med, that was the start of my consultant career. At the end of my career last year was all brought back to setting up the Nightingale Hospital here, where members of UK Med were key to setting it up and putting the protocols in place, and part of the senior clinical management team. So I'd like now to introduce a short video showing the solidarity and volunteering in the West Africa Ebola crisis.
I am Maria Dixon Kamara, an SCCHN graduate from the St. John of God Catholic School of Nursing. To be honest, life in Sierra Leone before the epidemic, it was much better. I started my nursing before the epidemic, but before I finished my nursing, then the epidemic came. Then we have to close down because of the epidemic. Nothing was going on because of the epidemic. Everything was standstill. It was really scary. It was really scary for health workers because there was little knowledge about the Ebola disease. In the early phase of the epidemic, there was no good IPC standards. There was no good working condition like the treatment centers. There was no Ebola treatment centers. Yeah, we keep on fighting because these people depend on us, these sick people depend on us. And if we, the health workers, are afraid also, yeah, we are afraid, but they are not seeing it in our faces. And emotionally, yeah, seeing people dying from sickness, a strange virus, not just a sickness, but a strange virus, which there was no cure at that time. And seeing people going through that, it was really emotional, because you sit there is nothing you can do. Only you will do something, but you know what I'm doing is just by God's grace, but I know what I'm doing. It's not the right thing how to treat this person, but I just have to manage this condition because people are suffering during that time and there is nothing you can do. So it's really emotional seeing people going through that, and every day hundreds of people dying, hundreds of people being infected. It's really, really not good anyway. It's really bad. When the UNMEER came, that was the first thing they targeted. They built these treatment centers. They build treatment centers where they admit these Ebola patients because they don't want to mix them up with these other patients at the same place. So they build different treatment center, which was very good. And also they provide more information to health workers on how to treat or handle these patients. So it was very, very great.
The response to Ebola was part of the expansion of the work of UNMEER. We had been largely a specialist, either surgical trauma team, although we had expanded further when we ran the hospital on the Iran-Iraq border. But when we'd responded to Gaza, to the conflict in Gaza, the NHS at a very high level became aware of what we could offer and the fact that we had a register and we had trained people. So when the Ebola outbreak occurred, we were asked by the NHS, would we recruit, coordinate and train the NHS volunteers to respond on behalf of the UK, to go into a variety of Ebola treatment centres funded by the UK government. And it's because we had this principle of working with the NHS, seconded from the NHS, having a register, having volunteers, that we could expand into outbreak response, very timely as it turned out for the subsequent work in COVID. But again, we had no shortage of volunteers. People knew how dangerous Ebola was, and we never had any problem. We had to stop the volunteering. We had to say, we have enough people. People kept coming forward. When Pauline, who you may remember, became so ill with Ebola, one of our volunteers, when that happened, we thought that the volunteering would go down. It went up. So Bruce Keogh, the medical director of the NHS, came to talk to the volunteers to say this just redoubles our efforts. So this volunteering is something we should all be proud of. But also we know that people will volunteer in dangerous situations. After we'd been to those earthquakes and the refugee crisis, we were asked by the British government then to go to Sarajevo. I was asked first of all to go and do an assessment mission for the government, which I did, and I mobilized quite a lot of aid as a result of that. I then worked for the World Health Organization. And then they wanted a much bigger program, which we called Operation Phoenix, which ran over the years of the war, 92 to 95, and we didn't really finish there till about 96. And again, we had no difficulties in recruiting volunteers from the NHS. The same principle, you volunteer and you are seconded from the NHS. The NHS has always been very supportive. And it was very dangerous. The airlift, that the first time I went into Sarajevo, I went in on the airlift that was run by the Italians. The second time that I went into Sarajevo, I wasn't on it, and it was shot down. So there were huge risks. The snipers were shooting at us all the time, and you didn't get used to it. It was, but we all managed to get through it. I once was, I left, so stupid. Sarajevo winter very cold, and I left the door open on the Land Rover and left the light on. And walking to our accommodation, I thought, well, the battery will go down, be flat in the morning, and so I walked back to the car. I walked back to the light, and it just went over my head and hit the roof of the car. So I thought, flat battery's fine. Who cares? But so we had all those scenarios. But in order to run a much longer program now, because if you go to sudden onset disasters, you have a disaster and then you deal with its consequences and the response fades out. In conflicts, though, it's continuous, and you have a series of shocks, if you like, different outbreaks of violence. They just keep coming. It's not going to tail off. And so we needed a much bigger program and to recruit from a much broader base than just the Greater Manchester area. And so we set up UK Med to draw from across the UK, and we've got just the same spirit of volunteering from across the whole of the UK. And we published it. We published all our findings, which is in a paper about Operation Phoenix, it's called, and you can look that up on the internet. We ran a whole range of programs during the siege. We took plastic and reconstructive surgeons in to repair all the terrible wounds that the people were left with. They survived it, but their complications were terrible. But also to try and get some sort of healthcare service going. And you get some very difficult dilemmas. People who you reckon had the early stages of cancer, but you had very limited diagnostic facilities. Do you support the starting of treatment or not? And if it can't be monitored, we had huge ethical problems like that to deal with. Medical evacuation was another one. Everybody wanted out, but countries won't take them, but they might take a few. They'll usually take children with limited health problems, so that's fine, we don't have to do much for them, but we'll never take the elderly, they'll never take mental health problems. What do you do? And you are trying to influence the decision. So it broadened our outlook, it broadened our experience, and it gave us the experience that to enable us to work later in Gaza. But coming right to the present day, we are now in Yemen, which is one of, there's been some news coverage of it with Jeremy Bowen recently. It is a terrible humanitarian crisis in Yemen, but we're there, and we have a video now from our head of office there, Mona.
My name is Mona. I lived with my family in a city of Taiz when the war broke out. We fled from the fighting, moving to Ib city. Then the fighting reached us, so we moved again. When the front line moved once more, my family said this is the last destination. We have to leave Yemen. I insisted and said this to stay and to help. Mother and children are the first victim in this war. Yemen was a poor country before, one of the poorest countries in the Middle East, but you can imagine the situation had become worse and worse after 7 years of conflict. There is a blockade, so food cannot come in. And because of farmer cannot grow food regularly, our people are starving. Half of the children in Yemen are at risk of acute malnutrition this year, with less than 50% of the health facilities functioning. Hospitals designed to care of vulnerable women and children are left out without basic supplies and medicine. Many skilled doctors and health staff had to leave because of the fighting. The public hospital were struggling before the war, and now the staff that they do remain here may go months without being paid. Actually, the front line of the war split the north and the south of the country. On map, we are called Yemen, but effectively we are two countries, with 80% of the people living in the north. UKMED is the first charity in 6 years to be guaranteed permissions to work in the north. So we must urgently help the people living here and begin rebuilding local health services. I have helped UKMED to set up an office in Yemen, but now we need your support to bring in the medical team in. With your generosity, we'll be able to train 100 surgical staff ready to provide life-changing surgery for many people and families who desperately need it. The war in Yemen, we say, is the forgotten war. The world had forgotten us. Funding, I'm asking for your help. Please, don't forget the Yemeni people.
Going back to the earthquake in Armenia, although all of us who were there thought we can do things better, huge changes were made in the international response. There was a United Nations Disaster and Assessment Coordination Team, of which I was a founder member, that would go in and assess what's needed. There was an international search and rescue advisory group set up to make sure that search and rescue teams were properly trained and prepared. And things improved. But then the big earthquake in Haiti occurred. And there's often certain events capture the public imagination, and Haiti already has a strong links with the United States in terms of medical missions coming there and people from around the world already working there in some capacity. When the earthquake occurred, there was a flood of medical and surgical teams largely going into Haiti. Many, like our team, were invited in, and we set up a field hospital. Others may not have been invited and had little experience of it. Those two things are important because I mentioned HCRI, the Humanitarian and Conflict Response Institute. The University of Manchester is unique in the humanitarian world in that it has a deploying NGO, non-government organisation, UKMED, within the university. It's an independent charity, but it's sited within the university alongside, physically, and the way we work, with an academic unit, the Humanitarian and Conflict Response Institute. So we have people who deploy and people who can research and teach about deployment. That relationship allowed us to review the activities after the Haiti earthquake, because there was a lot of concern about inappropriate surgery, or surgery being carried out by people inexperienced or not qualified. So we, as UKMED, had a team there for the 3 months after the earthquake, working with other NGOs, working with Merlin, to name one, and we could see the consequences of what other teams had been trying to do. So we were there for 3 months. But then because of HCRI and our academic connection, 3 months after that, that is 6 months after the earthquake, HCRI sent a research team in. Bertrand Tate, the executive director, French, could go and carry out interviews and research in French with the Haitian survivors of the earthquake. And we reviewed medical records working with Handicap International, and we could show that the difference in surgery between the experienced medical teams and the inexperienced medical teams was enormous, to the extent that teams like ours, teams like the Red Cross, MSF, would amputate limbs at the rate of about 7%. And that's the published data. That's what normally happens after earthquakes. One team was 85%. So they were making no attempt at limb salvage. And lots of teams, it was greater than 45%. So they didn't know how to save limbs, so they just amputated the limbs, which is devastating for those people who could have had their limbs saved, particularly in a very poor country. So using that information and the published information which went out into the literature and working with others, we worked with the World Health Organization to establish what became the Emergency Medical Teams Initiative, and is now an office based in WHO that has published standards for emergency medical teams, from how many needs to be in a team, what specialties, what they will do, and so on, and also to different procedures. We've also worked with the Red Cross to publish guidelines for the management of limb injuries after disaster and after during conflict. So huge step forwards, and UK Med and HCRI have been at the heart of that. In fact, the guidelines were published in the Blue Book, as it was called. It had a blue cover, but everyone just called it the Blue Book, and that's just been updated and republished this year. And we've also now published the Red Book, which sits alongside it, so as that gives standards for the care of patients in conflicts. How do you adapt the guidelines for a sudden onset disaster to a much more difficult situation of a conflict? So a huge step forward, of which we have been an integral part, and I'm very proud of all the work that people in UK Med and HCRI have done for that. So also, we published the Blue Book as a discussion document to see how the international community would react to it. It was so well received that in the just a few months after it was published, I was leading a team going into the Philippines after the big typhoon, and on entry we met the Ministry of Health, and they said they had the Blue Book, and they said, "How are you classified?" I thought, this is amazing that this, that so quickly it was adopted, which showed us that people understood the need for standards and wanted to comply. And now all the major countries have emergency medical teams. I've worked with the Chinese government on their team, with the Russian government, and I'm working with Kuwait and Saudi Arabia having teams. It's all expanded greatly. So at this point, I'd like to hand over to David. David Whittick is our chief executive, who, not wishing to spare any of your blushes, but has taken UK Med to an entirely different level with his vast experience and contact. So over to you, David.
Thanks, Tony. Can you? Yes, you can. Excellent. In front of that. Brilliant. Thank you. Cheers. I'm just going to talk for a few minutes, but one of the things I wanted to sort of lead off with was I first became aware of UK Med, or at least elements of UK Med, when I was working in Kosovo, in Pristina, in '99. And I was the country director for International Medical Corps at the time, small, obscure American NGO, don't worry about it. Now, the problem we all had was not necessarily the provision of healthcare, but how secondary care would be allocated to people. The secondary care in Pristina was delivered through this enormous Stalinist edifice, a 10,000 bed hospital. I think it was something like that, 5,000 to 10,000 beds, absolutely huge thing. And the problem at the time, and this was just after the NATO airstrikes, a lot of Kosovars had come back into Kosovo, NATO was there were still elements of the Serbian military, there were lots of paramilitaries, a lot of different political groups and a lot of weapons. And one of the centers for conflict was the hospitals, and particularly Pristina Hospital. There were actually live shootouts in the wards with Serbs and Kosovars shooting over patients' beds at each other. Genuinely, that happened. And so the United Nations came to all of the medical NGOs in the health cluster meetings, and they said, well, who's going to take this on? I mean, someone's got to take on this thing. Someone's got to run it. Someone's got to, sort it out. And collectively, we all took one big step backwards. You have to be crazy to do that. Well, they managed to find someone crazy enough. And they came out. There was NATO parked a British tank in front of the hospital. There was a team that came out from UK Med, Tony, and a bunch of British nurses and doctors, and they took on Pristina Hospital. And the rest of us, I think, were aghast because we thought, that's just crazy. But of course it wasn't crazy. It wasn't crazy at all. It was necessary. Somebody had to take it on. All of the other NGOs, and I was one of them, we all had our hands full with loads of other stuff, and it just seemed too bloody difficult, frankly. But it still had to be done. And I think it's that the spirit and the understanding of where the key, most life-saving act needs to be carried out, where the absolute point of highest vulnerability and where the requirement for the highest level of expertise is, that has been a sort of hallmark of what UK Med has tried to do since inception. And we try and carry on in that same vein. And in some ways, we have better tools now in terms of the frameworks and the understandings of how things should be done. The Emergency Medical Team Program, which was initiated after that Haiti earthquake, is one such tool and a really key framework. It sets standards, it decides what kind of services, it gives a straightforward typology, it looks at the qualifications of the staff, and so that a government in distress, when calling for assistance, knows exactly what they're going to get. They know if they want a type 2 field hospital, they know precisely how many surgeons it would be, how many operations it's capable of doing, what kind of other services it will be doing, whether it can do outreach, whether it can refer. They will know all of that because it is standardized and it's set down. And it is one of the most useful developments in international humanitarian assistance of the past 10, 15 years. And it's developing significantly. And I think success has many parents, but I think the EMT children, as they are now, can certainly point with some certainty that one of their parents is Tony. They may not know who all the others are, but one's definitely Tony. And as part of that emergency medical team family, UK Med has put itself at the forefront of this. So we have decided that we are going to absolutely be part of developing and building on the foundations that have been set by people from Haiti and then on. Up to now, UK Med, I think I'm confident, pretty confident, in saying that not only are we the most deployed emergency medical team in the world, and here's a map with loads of spots on it, that's where we've been deployed. And we've either deployed independently, as UK Med, as Tony and teams were doing back in the Armenia days and after that, or with partners as part of the British government emergency medical team. So we do both. And I think I'm confident in also saying that not only are we the most deployed EMT, but I think we're more deployed than all the other EMTs put together. Not that it's a competition, but I'm just putting it out there. So I think we have Tony to thank for much of this. It would have been impossible without our unique selling point, which essentially was the list of friends that Tony started off with back at the beginning, and then developed into a list of highly skilled professionals and consultants who are willing, able, and volunteer regularly to come out with us. Without that, frankly, it would have been exceptionally difficult to have set any of this up. And without support from Manchester University, HCRI, and many of our friends around the humanitarian sector. And there's never been more need for this. The convergence of the three main drivers of humanitarian crisis at the moment, climate change, infectious disease outbreak, there's a reason you're all sitting in masks, and state fragility and conflict. Those essentially are the drivers of pretty much all humanitarian crises that we see around us. And the need and the numbers of people affected are increasing year on year. And you just have to look at the United Nations figures, or indeed anyone's figures, to see that demonstrated quite adequately. And so for us in UK Med, we are trying to increase the capability and our capacity to address some of those problems. Again, at the sharpest point. There was a very good reason why Tony set up SMART. There was a very good reason why those teams deployed into Armenia into very difficult circumstances, and that's because that's where people are at the most need. And so for UK Med, we are now developing our own in-house capacity for those of you that have read and studied the Blue Book, as I'm sure all of you have. We have now our own in-house Type 1 field hospital, which we can deploy, pick up lock stock with people and kit and pharmaceuticals and everything else, and deploy. We have mobile medical teams which we can also deploy, as well as our work with the British government. Because the essential nature of what we do, as I say, is only growing. But I think what I really want to do is go back to the beginning of all of this and thank Tony for all his work, without which many of us here in UK Med would not be in gainful employment, but more to the point, I think would not have such a satisfying job. And it is inherently satisfying. And I think at that point, I just want to bring in maybe the last video which we wanted to show you, which is of one of our more recent deployments in Samoa for what was quite a devastating measles outbreak. Quite a large number of children affected, and very seriously affected as well, to the point where they needed international assistance for intensive care. Thank you.
It was quite an overwhelming experience. I don't think we've seen a bulk of children being sick this quickly in this short amount of time. A lot of these cases deteriorating over like less than 24-hour stay in hospital and then requiring intubation, and some of them did not make it.
We saw some challenging things, and sadly there are many children who are very unwell. You see the anxiety etched in parents' faces, and that's difficult to watch, and some of those parents had already lost a child.
Just to sort of bring things round a bit now. At the start of this work, I wanted to normalise healthcare in highly abnormal situations. That the circumstances may be difficult, but people in those circumstances, in those difficult circumstances, still require, must have the best possible care. And it can be delivered if you work at it. In order to get people released to do this work or to work more freely in it, we need a proper training program, we need professional recognition. Now in the UK, if you do any specialty, with the UK that is governed by the medical royal colleges. That's how it works for doctors in particular. But there isn't, so I'm a fellow of the Royal College of Surgeons of Edinburgh, and that, you know, that's my professional home. But for the humanitarian work, or for those who work in remote areas or very rural areas, who will have to do a variety of things, how do they get professional recognition? How do they keep up their training? How is it recognised? And so we've been working with the Royal College of Surgeons of Edinburgh, and I say we, that's UK Med, for a number of years now, to establish a faculty, that's a specialist body within the Royal College of Surgeons of Edinburgh, a faculty of remote, rural and humanitarian healthcare. And that's now up and running, and people are joining it, and we are working with them on how we develop, what is the core curriculum, what must people know, how do we train them, so as the future generations will have a clearer framework in which they can work and train. And this is across all specialties. The Royal College of Surgeons of Edinburgh has always been very far-sighted in that it sees itself as supporting healthcare in its broadest sense. So for our faculty of remote, rural and humanitarian healthcare, you can be a paramedic, you can be a nurse, you can be a logistician, you can be a doctor. So long as you are working within that area, the faculty will support your professional development and be your professional home, and give you ultimately a route to specialist qualifications. But it was UK Med that actually worked with the college to go through all the different routes and processes to get the faculty established, and I'm really proud of that, and it shows that UK Med is still working to develop the area of humanitarian medicine. The other thing is that the university here, the John Rylands, is going to archive all my papers. It's a remarkable feeling that you forget. Because I also worked at the Humanitarian and Conflict Response Institute, I was working with PhD students, and I could give them, they're working on earthquakes, they're working on humanitarian responses. Oh, well, here's the original papers about when Clinton met John Major, the UK-US mission. Well, I've got notes of the meeting, and I've got, and so on. And it was Bertrand Tate, who I've mentioned before, who pointed out to me that how valuable these things were. And so this triggered the establishment of a humanitarian archive, which I'm really pleased to be a part of. And we met recently to go through the stuff at home, and even going to take some artifacts. I think my wife Caroline is pleased that at last the flak jackets that are in the garage will find a home. And the third thing is that I did put all this together. When I was doing the archiving it and working out, I started writing things down. And I've written a book about it called Frontline. And I've been able to get copies such that there are some available tonight. I can guarantee that at least £5 of the purchase price will go to UK Med. And if we haven't got enough, I can always order some more, because the work of UK Med and much of what we've been talking about is in the book, and I would like to see any interest in the book also work to the benefit of UK Med. So I think that's it for now. Have we time for some questions? Happy to take questions if there are any.
Thank you, and just say, Tony, on behalf of myself and all the staff, I think you're such an inspirational leader, and it's been absolutely wonderful to be part of the movement that you've created, actually. And I think that we need to have a full, rousing round of applause for Tony and his absolutely incredible achievement and legacy. And thank you so much.